Yeah, okay. So, morning, good afternoon, good evening, everyone. Today is another very exciting ACNS YNS webinar today, and we have so many renowned speakers from all over the world. So we have, first of all, we have Professor Kato with us as our patron, and also for the chairs today, we have Professor Bin Xu, Professor and Consultant Neurosurgeon of Department of Neurosurgery of Huashan Hospital of Fudan University in Shanghai, China. He's also a world-famous bypass neurosurgeon. And also, alongside with us as a chair is Professor 𝑚𝒉𝒆 𝒀𝑵𝑺, who is the chairman of the Neurosurgical Department of University Hospital, Professor of Neurosurgery, Faculdade de Medicina of UFRGS in Brazil. Today, we have three speakers. The first speaker would be Professor Toshio, whose topic is the surgical anatomy for microvascular decompression surgery. The second YNS speaker is Professor Jimmy Wang, and who is talking about the surgical strategy and perfusion evaluation for 𝑣𝑚𝒆 disease. The third expert speaker is Professor Park, who will be talking about the very standardized technique of indirect revascularization for 𝑣𝑚𝒆 disorders. For the discussion today, we have Professor Oleksandr Woziak, who is the Chief of Neurosurgical Center, Clinical Hospital, Wiązali, and also President of Ukrainian Association of Neurosurgeons. And also Professor Ahmed Prison, who is the Professor of Kabul University of Medical Sciences, and also the Chief of the Neurosurgical Department of Aliabad University of Hospital, and also President of Afghanistan Neurosurgical Society. To moderate the session with me, we have Professor Sachin, Professor Dr. Yistem, and Dr. Esho, and Dr. Zhu Yisem. So without further delay, shall I invite our chair, Professor Bin Xu, to introduce our first speaker. Thank you, Professor Bin Xu.
Now let's invite the first speaker, Professor Matsushima, to present his experience in the microvascular decompression. Professor Matsushima.
Thank you very much, Chairman. I'll just wait. Okay. Good evening, ladies and gentlemen. I'm Toshio Matsushima from Japan, one of the Dr. Oton's fellows. Before starting my lecture, I would like to express my sincere appreciation to Dr. Liu and Dr. Yoko Kato. I am going to talk about the surgical anatomy and the procedure for the MVD. Dr. Oton's rule of three in the CP angle is very helpful to understand the MVD from the anatomical viewpoint. The slide shows the left CP angle. Three cranial nerve complexes and three cerebral arteries can be seen at different levels. When the SCA compressed the trigeminal nerve, trigeminal neuralgia developed. When the AICA does the facial nerve, hemifacial spasm developed. And when the PICA does a glossopharyngeal nerve, glossopharyngeal neuralgia is developed. In the lateral suboptimal approach, the cerebral hemisphere is an obstacle. The cranial nerves are located and hidden behind the cerebral hemisphere. Therefore, the approach to each cranial nerve should be different. The slide demonstrates the illustration of the three different approaches for MVD in the left CP angle. We use the infratentorial lateral supracerebral approach for trigeminal neuralgia, infraflocular approach for hemifacial spasm, and transcondylar fossa approach for glossopharyngeal neuralgia. Bony opening should be also made in different areas. In trigeminal neuralgia, we open the bone at the corner of the transverse and sigmoid sinuses the red area. In hemifacial spasm, the craniotomy is done below the incisura mastoidea, the blue area. The asterion is anatomical landmark for trigeminal neuralgia, and the posterior end of the incisura mastoidea is a landmark for hemifacial spasm. In glossopharyngeal neuralgia, the latter part of the foramen magnum is open. Let me explain trigeminal neuralgia first. Compression at any cysternal portion of the trigeminal nerve can cause the neuralgia. Therefore, we have to observe the entire cysternal portion of the nerve, including the Meckel cavity. Offending artery includes the SCA, AICA, and or vertebral artery. The most common offending artery is the SCA. In some cases, however, venous compression with the arachnoids cause the disease. Tumors such as the epidermoid tumor also cause the neuralgia without any neurological findings. This slide shows the course and segmentation of the normal SCA. The SCA can be separated into 4 segments. It goes between the 4th and the 5th cranial nerve, dividing into the rostrum and caudal trunk. The second segment, the lateral pontomesenteric segment, often compresses the trigeminal nerve from the superior side and will be often guilty. It is important to recognize the anatomical relationship between the trigeminal nerve and the SCA and the AICA. The illustration shows a compressing pattern by the SCA and or the AICA. On the MRI, we can preoperatively see the relationship between the trigeminal nerve and the compressing arteries. In most cases, the lateral mesenteric segment of the SCA forms a downward loop and compresses the trigeminal nerve from the superior medial side. On the axial view of the MRI, the SCA is visible medial to the trigeminal nerve, and on the sagittal view, it makes a downward loop below the nerve. Now we can see the relationship of SCA to the nerve on the 3D composition image. Next, I'm going to the surgical procedure of the MVD for trigeminal neuralgia and surgical anatomy necessary for it. An isosceles triangle craniotomy is done at the junction of the transverse and sigmoid sinuses. Then, 2 cerebral surfaces, the tentorial and petrosal surfaces, are being exposed. This slide shows 2 cerebral surfaces, the tentorial and petrosal surfaces, in the intraoperative views and in the cadaveric specimen. When the dura is opened, the subocular cerebral surface appears. You can see the transverse folia on it. The biggest folia is a great horizontal fissure. The wide subdural space on the tentorial surface provides an appropriate surgical field in which the SCA is shifted medially. In the approach, the petrosal vein, sometimes big one, is often an obstacle. MVD for trigeminal neuralgia can even be said that it is fight with the petrosal veins. Approaching the trigeminal nerve, the vein is encountered as a bridging vein. The preservation of the bridging vein is very important to avoid post-operative complications. Therefore, at this step, I would like to show you the anatomy of the petrosal vein. It is because some serious complications occur after sacrificing the veins. On the slide, we can see the tributary of the petrosal veins especially the vein of cerebropontine fissure. The vein of the cerebropontine fissure originates in the supraflocular system and goes above the 7th and 8th cranial nerve to the 𝑚𝒄𝒃 cavity. The draining terminal portion of the vein is not covered by the arachnoid membrane. Cerebellar retraction sometimes pull out the draining point of the vein. We have to be careful with the cerebral retraction, and first have to dissect the arachnoid membrane around the vein to make them free. This illustration shows a tributary of the Petrous vein and order over their exposure. The left upper CP angle. The first one is a vein of cerebropontine fissure. This vein should be exposed first. The second is an anterolateral marginal vein. I will show you the typical MVD for trigeminal neuralgia. Its approach and tentorial stitch sling retraction technique. Offending artery is a SCA. Here is a Petrous fissure. Follow the Petrous fissure. Then we can reach the supraflocular system. This is the 8th cranial nerve. I found the origin of the vein of the cerebropontine fissure there. I follow the vein to expose all tributary of the Petrous veins. I am checking the location of the bridging vein on the tentorial surface. Now we can see the 4th cranial nerve near the tentorial edge. The lateral mesenchymal segment of the SCA compresses the trigeminal nerve from the superomedial side. Offending SCA is being transposed for decompression. It was decompressed using the stitch sling retraction technique. I placed one stitch on the tentrium. I made a sling of the suture and pulled the SCA by it. Finally, I added the Teflon felt with glue too. This is a final view of the decompression. We experienced recurrent cases due to the adhesion of the Teflon felt at the early stage, about 30 years ago. It was placed between the trigeminal nerve and the offending arteries. So we changed the decompressing method from the interposing technique to transposing one. In the case of trigeminal neuralgia, we should not use the interposing technique. I will explain more the tentorial stitch sling retraction technique in the case of trigeminal neuralgia. This method is carried out by placing one stitch in the tentrium, passing and encircling the suture around the SCA, and then anchoring the artery with the sling of the suture. This technique allows the complete transposition of the offending artery. We reported our outcome of the MVD using the stitch string retraction technique. These 50 cases were operated on from 2007 to 2012 at the Saga University Hospital. Left graph shows a Kaplan-Meier curve presenting the ratio of the complete pain relief without medication. 1 year after the MVD, 88% of the 50 cases stayed in excellent condition, no pain. 5 years after the MVD, 83% of the cases. The next case is an old case in which the offending artery is a huge tortuous VA with strong arteriosclerosis. It compresses the nerve strongly. I'll show you the video. I operated this case more than 30 years ago. The upper portion of the left CP angle is being exposed through the infratentorial supracerebral approach. When the arytenoid membrane is opened, the large vein of cerebropontine fissure appeared. At the back, we can see the large VA compressing the trigeminal nerve, which bent in a wide curve. The vein of the cerebropontine fissure is coagulated and inside, even though it was large at that time. I was too young to have enough knowledge about the vein of the cerebropontine fissure. Luckily, nothing happened in this case. However, now I recommend you to keep the vein. I am checking the direction of transpose the offending VA. I decided to transpose it inferiorly behind the 7th and 8th cranial nerve using the stitch string retraction technique. I press a stitch on the dura mater just above the jugular foramen. The stitch was too large for surgery. I operated on this case more than 30 years ago. I did not prepare enough operative instrument. I make a string of suture and pull the VA by the string. Next, I will check the medial side of the trigeminal nerve. The SCA compresses the nerve and make an indentation on the nerve. Therefore, the offending SCA is being transposed medially for decompression. It was adherent to the tension by Teflon felt and glue. This was a final view of the decompression, both arteries. Next consideration is the vein. A question is, can veins be offending vessel for trigeminal neuralgia? To obtain the answer, I studied my 168 operative cases in 2003. In 7 of the 168 operative cases, offending vessel were veins. The MVD was effective in all cases. The transverse pointing vein was found most frequently. I'll show you one case. Left 2 slides show intraoperative photo in a case of the left trigeminal neuralgia. The transverse pointing vein compresses the nerve from the below at the Meckel cavity. Next is the hemifacial spasm. Vascular compression at the root zone of the facial nerve causes the spasm. Offending artery includes the PICA, AICA, and or vertebral artery. The most common offending artery in the AICA in a case of Japanese. I have never seen a case in which the vein causes a spasm. This cadaveric specimen demonstrates the anterior view of the left CP angle. The lateral portion of the pontomedullary sulcus is a concave, called supraolivary fossette. It is indicated by a yellow arrow. The facial nerve is situated medial to the acoustic nerve, and the root zone of the facial nerve is present in the supraolivary fossette. It has generally been believed that arterial compression at the root zone of the facial nerve causes spasm. There, the arteries such as the AICA, PICA, and VA often change their courses. The right half shows a histological specimen of the cutting face of the pons at the level of the exit zone. The myelination is absent at the root exit zone. This is a suspected reason why the root exit zone is guilty for the spasm. The slide demonstrates the anterior view of the brainstem and the arteries. The AICA and or the PICA change their courses in the supraolivary fossette. On the right side, both AICA and PICA course near the exit zone. The high origin PICA compress the facial nerve, making upward loop. This slide shows the axial view of the MRI in the case of the left hemifacial spasm. The facial nerve can be seen in the internal auditory canal, but the exit zone of the facial nerve is not present at this level. As you can see on the MRI of the sagittal view, the exit zone of the facial nerve is present at a lower level than the level of the internal auditory canal. In the case of the axial view, the flocculus and pontomedullary junction as a landmark to find the root exit zone of the facial nerve. Next is positioning. The positioning is very important in the surgery of the hemifacial spasm. It is because the patient's shoulder is an obstacle in the line of the thigh, and for the surgeon's hand, we need enough working space behind the patient. The head of the patient is tilted to the healthy side and anteriorly. The illustration shows the 𝑚VD procedure for the hemifacial spasm, which is an infrafloccular approach on the left side. To expose the exit zone of the facial nerve, we have to go through between the flocculus and ninth cranial nerve. Anatomical landmark is the choroid plexus protruding from the foramen lucica. It is situated just in front of the origin of the ninth cranial nerve. After separating the arachnoid membrane and the rhomboid lip from the 9th and 10th cranial nerve, we retract the flocculus superiorly. Then we can see the exit zone. The direction of the retraction of the flocculus is very important. The AICA, the most frequent offending artery, gives a rise of the perforating artery around the facial nerve exit zone. The right side illustration demonstrates the perforating arteries. Perforating artery run from the cranial side to the caudal side. Therefore, When we place a few pieces of prosthesis under the compressing artery, we had better insert them from above to below. In the case of hemisphere spasm, we sometimes use the interposing technique depending on the cases. The facial nerve is a motor root, so adherence is not so big problem, different from the trigeminal nerve, the sensory nerve. I'll show you the typical procedure using the video, infraflocular approach. The left cerebromedullary system is being exposed. The lower cranial nerve, VA, and the cerebral artery, PICA, are visible. The arachnoid membrane is being incised and origin of the 9th and 10th cranial visible. Operating microscope is being rotated to see more laterally and inferiorly. Now we can see entire portion of the 9th cranial nerve. We can see also the root zone behind the nerve. When the cerebral artery is lifted up, we can see the indentation on the root zone of the facial nerve. When the flocculus has been retracted superiorly, a wide cisternal cistern between the 9th cranial nerve and the 8th cranial nerve can be seen. The vertebral artery and the pica run parallel to each other. The ica runs from the pons near the root zone of the facial nerve to the internal auditory canal. ica directly compress the root zone. Perforator is short, so I inserted the Teflon felt between the offending AICA and the pons near the root zone. Finally, the indirect compressing VA was also decompressed by interposing method. These illustrations shows different operative views depending on the offending artery. The AICA divides into the rostral and caudal trunks. The roof of the offending PICA is often hidden by the 9th and 10th cranial nerve. The vertebral artery often compresses the facial nerve directly or indirectly with another offending cerebral artery. The third is the glossopharyngeal neuralgia. The offending artery are the PICA and or the AICA. Most frequent one is the PICA. Some tumor, such as the epidermal tumor, rarely cause the glossopharyngeal neuralgia. In the early 1990s, the diagnosis to apply the MVD for the glossopharyngeal neuralgia was difficult. Since I studied the anatomy of the pica in Roton lab in 1980, I knew the relationship between the PICA and the lower cranial nerve. The PICA was most frequently found as the offending artery. Then I noticed three features of the offending PICA in the cases of the glossopharyngeal neuralgia. They are first, originating at a high level. Second, making an upward loop. And third, causing in the supraolivary fossette. You can see these features on the MRI and the MRA. The illustration in the lower triangle shows the relationship between the PICA and lower cranial nerve in our cadaveric study in 1980. Of the 50 side, 3 PICA ascend anteriorly to the gross pharyngeal nerve. In 1990s, the surgical result of the MVD for the gross pharyngeal neuralgia was not so good. The surgical complications were many and severe because of the deep surgical field in the cerebromedullary fissure. The anatomy, which was a relationship between the lower cranial nerve and the offending artery, pica, was not well known. I started the MVD for gross pharyngeal neuralgia in 1997, and I gradually changed my procedure. I began to approach the gross pharyngeal nerve from posterior inferior side through the transcondylar fossa approach. Now I utilize the transcerebromedullary fissure approach too, to obtain the wide operative field in the cerebromedullary fissure. I operated on 35 patients in my life, and in 100% patients, the neuralgia disappears just after the MVD without any big complications. I'll show the MVD procedure. The region is the right side. The position is a lateral recumbent position. The dura mater was open. Posterior inferior portion of the right cerebral hemisphere is visible. When the inferior portion of the cerebral hemisphere is being lifted up, the fall of the cerebromedullary system is visible. The upward loop of the PIC and the AIC echoes between the 9th and 10th cranial nerve, and both compress the gross pharyngeal nerve. First, the AICA was transposed upward for decompression. Now I'm moving the AICA. Then the loop of the PICA has been also pulled out posteriorly for decompression. The pull-out loop of the pica has been fixed to the dura mater with a stitch string retraction technique. The transposed ICA was fixed to the cerebral cortex by glue. Decompression of the both offending artery is completed. I wrote on the MVD in my textbook, Microsurgical Anatomy and Surgery of the Posterior Fossa. So please take a look at the textbook if you want to study so much. Dr. Lawton told us the combination of the knowledge of the microsurgical anatomy and the use of the operating microscope improves the technical performance of many neurosurgical procedures. Recently, the endoscopic surgery is coming. It is very nice for the MVD too. It makes the procedure change a little. However, the surgical anatomy is the same. Thank you for your attention. Thank you.
Thank you so much, Professor Toshio. I'll definitely read your textbook to study. Shall I invite Professor 𝑣𝑚𝒆 to comment on Professor Toshio's lecture and also invite our discussant to discuss his presentation? Thank you, Professor 𝑣𝑚𝒆.
Professor Matsushima, thank you very much for your very informative presentation and covers all the posterior forces decompression MVD. Yeah, thank you. We learn a lot. And by now, there's a trend that MVD surgery is now more and more performed by endoscope. How about your opinion?
Yeah, we have to use the endoscope in near future But, in my case, I'm too old, so I'm not using the endoscope. Young generation, should perform the endoscope. But procedure is changed, but a little change. So surgical anatomy is the same.
Yes.
Professor Kato, any comments from you, Professor Kato?
Sensei, you have to unmute your mic, Sensei.
Matsushima Sensei, thank you very much for your great talk. Congratulations.
どうもありがとうございます。
Just I want to ask because you mentioned about the responsible vessel is not an artery but also the vein. But I think just you can tell us what is the mechanism, because we thought the offending vessels has maybe hyperexcitability of the some effect for the nerve, I think. So do you think the venous system has such kind of some hyperexcitability for the nerve? And also, if there are some attachments of the nerves, so should we also detach not only the artery but also the vein? Because sometimes so many venous system is covered, the fifth nerve. Thank you very much.
I don't know exactly correct answer, but in my experience, in the case of the trigeminal neuralgia, some case has no offending artery. But when the clinical symptom is typical, we can open the craniotomy to see the trigeminal. Some arachnoiditis and venous compression were found. And also, I showed in my lecture, I checked my operated cases. So venous compression is also, detachment of the vein is resulting in the no pain. So in the case of the trigeminal neuralgia, you should consider the venous compression. I don't know the mechanism. But in the case of the hemiphageal spasm, I have never seen the venous compression, only arterial compression.
Thanks so much. Okay.
Professor Mitsushima, I just noticed that in your presentation, you showed a video of your suture to stitch on the tentorium to fix the artery. It's quite nice. And how often you use this technique?
Everybody told me, stitching inside the cranium is very dangerous. But from my viewpoint, not so dangerous, particularly tentorial surface, infratentorial supracerebral surface. Bridging vein is few, and also bridging vein is located medially. So when we approach the laterally on the tentorial supracerebral surface, we can have enough space to use the stitch. Yeah, I learned from the cadaveric specimen.
Okay,
and also,
thank you. Jimmy raised up his hand.
Oh, yes, Professor Toshio. I have some question about my experience. I have maybe 5 to 10%, usually in old patient, after the surgery of MVD, they got the delay hearing loss or hearing impairment. Not immediately after surgery, usually post of 5 days or 7 days later. And my hypothesis is usually they are old men and they're for the surgery and even the trigeminal MVD, not hemifacial spasm, we destroy the arachnoid protection membrane and make the surface for the surgical field and make the strike nerve become easily to be stretched after the surgery. Do you, how is your experience? Do you have similar experience about delayed hearing impairment after those kind of surgery?
You are talking about the not hemifacial spasm, but trigeminal neuralgia?
Yes.
I have no experience. We, in the case of trigeminal neuralgia, we approach the Meckelke. So we did not see the internal auditory canal and 7 and 8. So we are working upper part of the CP angle. So hearing disturbance is no problem in the case of the trigeminal neuralgia.
That's correct. So right now we do regular hearing exam after the surgery 1 month later. And around 5 to 10% will hearing decrease after the surgery.
No. In the old time, people started the MVD. Everybody approaches like the acoustic tumor. But now we are different approach. We are going to lateral supracerebral approach. So we did not see and a little far from the internal auditory canal. I have no problem with the hearing.
Okay, thank you very much.
Sensei, Jimmy Sensei, can I ask you, Dr. Jimmy?
Yes.
So during the surgery, the MEP is the normal? Your case?
Yes. So we regularly check the hearing before the surgery for all kind of MVD. And we found around 5% to 10, there's a hearing loss. Not totally, usually partial, and sometimes transient. But there's some patients will have hearing problem and delay after the MVD surgery. And most of them are old patients.
Do you do the MEP monitoring during the surgery?
Yes, always.
Is it no problem during surgery?
Yes, during surgery is no problem. And even the immediate post-op, the hearing like it's okay. So I feel they happen delay, not immediate after the surgery.
So we don't have such case. Thank you.
So there are 2 questions in the chat box about Professor's lecture. The first one is about, is there any incidence of 𝑙𝑒𝑐𝒑𝒆𝒄 after operative interventions? If it's then what's the treatment? The second question is about the outcome between the endoscopic assisted surgery and also the microscopic approach. Is there any difference? Both of the questions are from Dr. Raffel. So the first question is about the 𝑙𝑒𝑐𝒑𝒆𝒄. The second question is about between the endoscope and also the microscope.
Professor Matsushima?
I have never experienced. And also second question, I have no answer. Because I am not using the endoscopic surgery. First question, I have no experience. Why? Anyone have a experience and answer? We decompress the offending artery. We did not incise the trigeminal nerve.
I see. So maybe also shall I invite Professor Aliseng for your comments?
Me?
Yeah.
Yes.
Yes.
Okay. Professor Matsushima, thank you very much. So I want to use this chance to thank you for your great publications which we have in our journals. I studied dedicated to anatomy of posterior fossa. From time to time, I look through them because they're really classical. Thank you for this big job. At the discussion, I'd like to highlight some points of your presentation. I really enjoyed it. So I'd like to explain for our younger colleagues that the initially procedure of microvascular decompression was proposed as a procedure of putting some Teflon pad in between compressing artery. But you went further. What you do? You perform very wide arachnoidal dissection. You open everything. This is the point. This is the point. And because you know the operation, when you only put the pad inside, usually lead to pain recurrence in 2, 3, 5 years, 10 years, you know. So it's not sufficient, it's not enough. So this approach, when you create a new anatomical syncope, new anatomical interposition, and then you use the stitch for fixation of the artery. So it's a great, some years back, it was a pioneering technology, and thank you for this, that you really showed it, because I also shifted from when I started. My first surgeries were, I also put it on the pads. Then I wasn't satisfied. I moved further. Now I perform wide dissection, and you know, in some cases, I find another reason of compression. You see the one big artery, then you go move to the brainstem and find another, maybe real compression with the real strangulation in this. So this technique is great, and thank you very much for this great technique. My question is about one more decompression, which was proposed by Janetta, you know, this publication, about 10 cases, for decompression of anterior lateral brainstem for diabetes insipidus. Have you ever had a case like this, and do you think is it worth to try for us? What is your option? No, me too, but I remember this publication. He reported 7 improvements in 10 patients after this decompression.
Yeah.
It's interesting.
I tried the MVD, trigeminal neuralgia, hemifacial spasm, and glossopharyngeal neuralgia, and arterial compression of the brainstem, medulla oblongata.
Medulla oblongata.
Yes, and I operated on the 5 or 6 patients. That is very good. That is very good. And also, I tried the hypertension several times, several cases. But after moving to the different university, I had no chance to continue the decompression of the hypertension.
But you recommend? Do you recommend it to try?
Yeah.
Yes, recommend.
There is
Thank
a possibility.
Thank you very much. Thank you.
Any comments from our Sanchez, Professor Eppiros?
Well, congratulations, Professor Matsushima. That was a fantastic presentation, and your book is well known all over the world. My question is, what do you do when you operate on a patient and the pain comes back?
Pains come back. Okay. When the patient has a relief 1 year after the MVD, I'll again operate on the patient. But in the first surgery, patient will not get the pain relief. I never operate on the patient, just medication. Do you understand my English?
No, I understood perfectly. And the other question is, in every 100% of cases, do you always find some kind of compression, either for neuralgia or for hemifacial spasm? You always find some vessel disturbing the nerve?
In the case of the hemifacial spasm, I operating on about 500 cases. Only one case has no arterial compression. So in the case of the hemifacial spasm, you can believe that 100 cases has a arterial compression. But on the other hand, in trigeminal neuralgia, arterial compression was found about 80%. Another 10 or 15%, we will find the venous compression was arachnoiditis. When the patient shows a typical trigeminal neuralgia clinically, we can operate on the patient. So found the venous compression was arachnoiditis. Okay.
Okay, and my last question. If the patient is not, due to some sickness or oldness, if he is not able to be operated on, what is your management of the patient?
Please again.
Patient has a trigeminal neuralgia, but patient is very old, no clinical conditions for it to be operated. What is indication?
We have a medication. So first we'll give the medicine, Tegretol or something. Then,
okay, but if the patient is resistant to medication, this is my question.
Depending on the dose of the medicine, sometimes, I don't know the age of the patient, maybe 80 or 85. I have 2 cases of the cardio attack after the MVD. Both is survived, but I had a hard time 1 or 2 days after the surgery. So it is difficult to recommend the MVD to all patients, particularly after the 75 or 80 years old.
今日の先生、放射線治療のことを聞いてるかもしれません。
はい。Radiation therapy is some case effective in some cases, but I am not sure about the effect and side effect of the radiation therapy. I have seen a few cases, severe pain, facial dysesthesia after the radiation therapy. So I don't like the radiation therapy. Sorry, I have no correct answer to you. But in my preference, radiation therapy is not first choice.
Is there a comment from Professor Pritchard?
Okay. Yeah, I think sometimes.
Thank you, Professor.
Thank you, Professor Mitsushima. But I have a real case that the patient was have an indication for decompression, but she is a mid-age female patient, and but her brother is a traditional Chinese doctor, so he used acupuncture to treat her, and it's really fantastic. And it's totally relieved. Now it's almost 5 years ago, no recurrent. So I don't know why, but it's really effective. Use Chinese acupuncture technique.
Yeah.
I
have no experience.
I saw Professor Priestley want to say something.
Okay, thank you. Thanks very much. Thank you, Matsushima. A great presentation. I'd like to your opinion about which countries they haven't decompression opportunity, and what is your advice for doing in persistent cases? And second, what's your advice for recurrent neuralgia after decompression? Thank you very much. Arigato.
どういたしまして。
I have a message echo to the Professor Shipping about the acupuncture. My team, I have a senior acupuncture Chinese medicine specialist. So sometimes I refer patient to him for acupuncture for trigeminal neuralgia. And I think the response rate is around 20 to 40%. So it's effective. But total recovery rate is very low. So so I think you can treat it as one of the option or like one of the drugs, something like that. But if the patient is not work, you still need surgery.
Yes, I know. But it's very effective in some cases, yes.
I see. Professor Mitsushima, also, is it also to the hemifacial spasm and also the glossopharyngeal neuralgia in China with the acupuncture?
Because this is my subspecialty is the vascular disease, so I don't research this kind of field. So I just know some cases, but not systematically to research it.
I see. So thank you.
トラリスタの先生が再発した時の治療は何かありますかって聞いてました。
はい、再発した時の治療のことを話してましたけど、さっき私が言ったのは加藤先生、じゃあ訳してください。最初の手術で効果があって再発したやつは再手術したがいい。しかし、最初の初回の手術から痛みが完全に取れなかったやつはもうせずに、できるだけメディケーションでいった方がいい。それで放射線治療はね、サイドエフェクトがひどいやつがあるんですよ。だから僕はもうギリギリまで、いわゆる薬で効かないじゃないかって言うけど、本当に発疹が出て、入院させないかんぐらいまで薬の量を増やしてね、放射線治療はギリギリまで待ちます。すいませんけど、訳してください。
Dr. Fawad, thank you very much for your question to Dr. Matsushima. He wanted to say, because you asked him the recurrent case. So the Matsushima sensei emphasized that at the first surgery, it was an effective case. Then he will do the second surgery. But from the beginning, it does not work treated by surgery. So maybe he can push the more medicine at the maximum dose. He doesn't want to recommend the radiosurgery because of so many side effects. That is his answer to your question. Thank you. Great to see.
ありがとうございます。Thank you very much.
ありがとう。
ありがとう。Ben?
Okay, thank you, everyone. So if there's no more further questions, shall we move to our next speakers? So shall I invite our second chair, Professor April, to introduce our second speakers and his topic?
Well, okay, the second speaker, as I understand, is Professor Jimmy Schwank, and he's speaking about surgical strategy and perfusion evaluation for Moya-Moya disease. Please, Dr. Schwank.
Okay, so all of you see my slide?
Yes.
Okay.
Yes.
So greeting all my friends in ACNS, the respect President, Professor Yoko Kato, Chairman of Professor Roger Kuti, Professor Shipping, and all of the ACNS, my friends. I'm very honored to have chance introduce. Wait. I'm very honored to be invited to present my research study. The topic is the surgical strategy and the perfusion evaluation in Moya-Moya disease. My name is Jimmy Zhang. I'm coming from Kaohsiung Changkeng Memorial Hospital, the largest medical center in southern Taiwan. And I'm specialized in brain tumor, scar-based, epilepsy, pediatric, and bypass surgery. So today is a research report. I will start from the introduction of surgical strategy and perfusion evaluation for Moya-Moya disease. The Moya-Moya disease is a cerebral vascular disease. It is characterized angiographically by progressive stenosis or occlusion of the terminal ICS. It is often accompanied by the development of the collateral networks, which seems provide an alternative route for cerebral perfusion. However, the pathophysiological bypass is imperfect. The attempt to compensate for reduced cerebral perfusion often fails, leading to the well-known clinical manifestation of the disease, including ischemia, stroke, and TIAs. Moreover, the fragile collateral networks have a propensity to bleed, which may result in hemorrhagic stroke. The term Moya-Moya disease is reserved for those cases in which the intracranial vascular change are primary and truly idiopathic. Moya-Moya syndrome is defined as secondary Moya-Moya or Moya-Moya phenomenon, which is used with the intracranial vascular change that occur in association with another condition, such as radiation or NF1. The etiology is unclear, but the genetic mode of inheritance is considered possible because of the higher incidence of the disease in Asia. The critical feature have two peaks, shows different clinical features. And even in pediatric population, the disease features show spectrum in different age groups. This makes the Moya-Moya research difficult to uniform cohort due to variable manifestation according to the age and the diagnosis. Cerebral angiogram is the golden standard for the diagnosis. In the past time, the Professor Suzuki established the grading system by cerebral angiogram. He hypothesized that the disease progression and severity based on the angiographic staging, which are proved not correct. And even we had modified Suzuki grading since 1999. The disease staging seems not only based on angiographic picture. So patient may have bilateral ICS occlusion with florid collateral vessels and remain asymptomatic. In contrast, patients with angiographically confirmed mildly stenotic or pre-occlusive disease may experience severe ischemia symptoms. The major question for DSA evaluation is DSA-based criteria cannot reflect clinical stability. And the second, limitation of an angiographic study used to evaluate cerebral blood flow in a quantitative and quantitative manner. The most likely reflect the complex interplay of the many factors that governance cerebral blood flow, including age, systemic factor, the quality of the rest of the cerebral circulation, and the collateral network. So in the 21st century, perfusion studies are added to try to decide the severity of the disease. In 2010, the burning 𝑚𝒉𝒆 grading system are established and combine the angiographic finding, MRI finding, and perfusion finding with FDG pad with H2O oxygen 15. The tool of the perfusion is a serious question. There are a series of perfusion tools. Previous attempts at the hemodynamic assessment have been hampered by lack of the suitable method on the one hand and consistency between centers on the other. Among the methods available to monitor cerebral hemodynamic, cerebral vascular reserve or oxygen extraction fraction, we call OEF, using positron PET were the most commonly used method. The OEF methods are problematic in that they require invasive procedure and most costly are limited in availability and in need the ironing radiation. One of the measures of the impaired cerebral hemodynamic is cerebral vascular reactivity, defined as the change in cerebral blood flow in response to a vessel-active stimulation, such as CO2 challenge or diamux challenge. In healthy subjects, the relationship between PaCO2 and cerebral blood flow is sigmoidal in shape, but is near linear over a large range of PaCO2. However, patients in insufficient perfusion may exhibit a regional decrease in cerebral blood flow during hypercapnia. This is known as vascular steer, arising from redistribution of blood flow away from the area with exhausted vascular reserve to vascular bed, with intact reserve and therefore an activity to lower flow resistance. Another method is single photon emission, CT, we call SPECT. Analysis allows detection of hemodynamic compromise using non-quantitative relative measurement comparing the healthy hemisphere with the diseased one. However, methodological limitation to a bilateral disease as 𝑚𝒉𝒆 disease was noted. Novel MRI technique may contribute to the hemodynamic assessment. They include T2 star DSC weight MR perfusion, or T1 weight DCE MR perfusion, or SL, or modern resting state for MRI for perfusion. And also, traditional CT perfusion with now analysis with modern AI technology. So let us make a summary of limitation of perfusion study. First of all, most of the perfusion studies do not provide absolute value. The second, 𝑚𝒉𝒆 disease or bilateral involvement make it difficult to calculate oxygen extraction fraction. The third, many bias affect perfusion results, make it difficult to be compared. And the fourth, limit data make difficult to provide normal range. And the pure PET scan or MRI perfusion gives no indication of dynamic autoregulation. One of the measurements of impaired cerebral hemodynamic reactivity defined as the change in the cerebral blood flow in response to vessel-active stimulation, such as CO2 challenge or diamux challenge. This is what we call cerebral vascular reactivity. Rather than increased OEF, this is more likely to indicate the hemodynamic change that increase the risk of the stroke. So let's go back a little bit to the clinical treatment of the 𝒉𝒆 disease and its debate issue. The ECIC bypass surgery are the main treatment of the 𝒉𝒆 disease. With current guidelines, no effective medical treatment. Patient with defective diagnosis under the cerebral angiogram with clinical stroke or repeat TIA are the candidate for the revascularization surgery. The level of the evidence of the recommendation are only class 3. So why surgery? The old study without good cohort study show untreated 𝑚𝒂𝑚 disease causing significant neurological impairment in 70 to 80% of affected children. And if the patient takes surgery, the outcome will become much more better. The long-term follow-up for 𝑚𝒂𝑚 disease without surgery reveals that the ischemia type show poor outcome with recurrent attack. The largest case series in China, and you can see. So the treatment right now, not only direct revascularization, some study shows indirect revascularization is also effective. So what patient need to do indirect and what patient need to do direct or both? Here is in debate. In pediatric, we usually think the indirect is okay. But in adult 𝒂𝑚 disease, more and more studies shows patients need to do direct bypass, even in the meta-analysis. So because the poor evidence, there are no accepted grading system and diagnosis tool for the 𝒂𝑚 disease. I believe the new perfusion protocol for grading system and surgical evaluation is needed. So we create the new tools. One is the automatic CT perfusion with AI analysis. We use RAPID. And another, we pick DSC perfusion MRI with CO2 challenge. The RAPID is an operated independent image processing and visualization tool created by Professor Albers for acute ischemia stroke patients. After 2015, the Big Five in NEJM, this tool has enhanced the triage and predictable of functional outcome in patients undergoing mechanical thrombectomy. So you can see in the old tool for neuromba evaluation, now we use automatic CT perfusion analysis with RAPID. It's the new tool for neuromba evaluation. The old tool for the autoregulated failure, we use oxygen 15 PET with diamox challenge. And right now, the new tool for the autoregulated failure, we create MRI DSC perfusion with CO2 challenge. And the old tool for the cerebral flow analysis, we usually use transcranial Doppler. And now the new tool for the cerebral flow analysis, we use non-invasive optimal vessel analysis we call NOVA. So I'll show you some cases and those evaluation results. The first case is a pediatric 𝒂𝑚 disease with ischemia type. 4 years old boy, he has sudden onset right hemisphere just after the post-liver transplantation, day 14. He is a biliary atresia and status post-liver transplantation. After the surgery 2 weeks, he has stroke. Non-finding, no hemorrhage in CT scan. In MRI, you can see the left side MCA territory acute infarction. And multiple artery stenosis is found bilaterally. So this is my 3 major tools for 𝒂𝑚 disease: the DSA's MR perfusion with CO2 challenge, and CT perfusion with RAPID analysis. And we also screen as an Alagille syndrome for this patient. In angiogram, you can see the stenosis of major trunk of bilateral distal ICA. It's right side Suzuki grade 3, left side Suzuki grade 3, and no new stroke, multiple stenosis. For DSC MR perfusion with CO2 challenge test, usually the data for the CO2 challenge you will see in each territory are all white color. That means after the CO2 challenge, they got increased volume, increased flow, and shortening of the perfusion time. So if you see the red color, it means the auto-regulation has failure. And just like the oxygen 15 with PET study and the diamond study. Usually when a patient with impaired perfusion, it will delay perfusion time at first, then decrease the flow, and at last decrease in the volume. So you can see in this patient, his autoregulation function is not very good. For the rapid study, you can see the both sides have Tmax prolonged more than 6 seconds. So we do the surgery for the kids. For our surgery, we do the right side first. We have very good surgical image 3D reconstruction for pre-surgical simulation. So we can predict the donor vessel before the surgery. Under this prediction and intraoperative monitoring, we can create a very small craniotomy, usually around 3 centimeters. And we do direct and indirect at the same time. And after the surgery, we'll check with the intradoppler detector. So after the surgery, 4 months later, we check the perfusion again. As MR perfusion DSC with CO2 challenge, you can see the more white area that shows the autoregulation improving. And for the rapid, there's a little bit increase of improving in the left side and right side. This is just the 4 months after the first surgery. And then we do the second surgery for the left side. Also with direct and indirect. And this is 1 year later for the second surgery. You can see in the rapids, the perfusion with Tmax threshold have great improvement. And also the autoregulation function under the CO2 challenge with DSS MR perfusion are restore his autoregulation failure. The second case is an adult 𝑚𝒉𝒆 disease, also ischemia type, with TIA. So also he was found with MI, and we confirmed the diagnosis under angiogram. The right side is Suzuki 4, and the left side is also Suzuki 4. This is initially MR perfusion, DSC with CO2 challenge. You can see the autoregulation function is not very good. And the rapid study, you can see bilateral impairment, especially the right side is more severe. Compatible is clinical TIA. So we do the right side surgery first. Also, we do direct and indirect at the same time. 6 months later, we re-evaluate this patient. You can see the right side of the hemisphere, there are new wave shape, black out. That is the recovery of the perfusion after the surgery under the rapid study. So this is a very dominant evidence that shows how we do bypass effective. So it's very dominant. And we do another side surgery for bypass, also adult and also direct and indirect. And you can see the follow-up will restore his autoregulation failure. And also his perfusion Tmax improve near normal. So in recent 3 years, we have around 64 operations for bypass. Most of them 𝑚𝒉𝒆, and some is arthritic cerebrovascular disease. So I can quickly show the data, and you can see the perfusion with Tmax improve after the surgery. And also the autoregulation function was restored after the bypass. This is maybe the most severe patient in recent 3 years. You can see bilateral, his Tmax are very impaired with perfusion. And after the 2 surgery of bypass, his perfusion got almost normal. And his TIA and the stroke are already all stopped. And this patient is the 𝑚𝒉𝒆 phenomenon. It's only one side. And you can see it also get good result in perfusion. So this patient, he has very severe autonomic autoregulation failure. And you can see after the surgery, we restore his autoregulation function. So you can see the effect is very dominant under this evaluation tools. So in the past time, for the autoregulation failure grading system, it's based on the oxygen 15 PET study under the diamond stimulation. For stage 1, the cerebral blood flow decrease and the volume increase. Stage 1.1, the 2.1 increase O2 extraction. And stage 2.2, no increase of O2 extraction. And stage 3 is infarct. So based on this grading system, we create a new grading system of autoregulation under DSC T2 star MR perfusion and the CO2 challenge. The stage 0 is normal. You can see after the CO2 challenge, the volume flow increase and the time improvement. Stage 1 autoregulation failure, it means the time delay, but the volume and the flow are still increased. And the stage 2+1, the increased O2 extraction, you can see the flow decrease. And the stage 2+2, you can see the volume decrease. And the stage 3 is infarct. So at the end of the take-home message, I believe the new perfusion protocol for grading system and the surgical evaluation can be established with the autonomic CT perfusion analysis and DSC perfusion MRI with CO2 challenging. And our goal is to try to redefine the bypass effect in perfusion study and autoregulation evaluation. And we try to redefine the surgical indication for the bypass surgery for 𝑚𝒉𝒆 disease. And third, we try to redefine the surgical indication in atherosclerotic cerebral vascular disease or other cerebral vascular disease such as radiation-related vasculopathy. So right now we have 3 clinical trials on my team. The first trial is about 𝒉𝒆 disease and 𝒉𝒆 syndrome. And the second is the radiation-related vasculopathy. We have a lot of patients with radiation-related vasculopathy. Most of them stand for the stent. But in my study, most of the radiation-related vasculopathy has very good perfusion and almost normal autoregulation. I feel this patient may be over-treatment. And the third trial is the quantity evaluation for DSC MR perfusion with CO2 challenge in healthy volunteer and in patients with cerebrovascular stenosis occlusion disease. Because the low risk and the low mobility in my bypass surgery, our stroke team right now try to send some intracranial atherosclerotic stenosis occlusion disease to me. This kind of patient are not indicated because the previous ACNS YNS big trial study. But in my study, right now we have 12 patients. They come to me because of recurrent stroke, and there's no medical way to stop them. And after my bypass surgery, their stroke or TIS stops. All of them have good recovery. So I think about the intracranial atherosclerotic stenosis occlusion disease for bypass surgery, maybe in the future, we can have a high quality inclusion criteria and surgical technique, and we can create a new indication for the bypass surgery in this kind of patient. I thank you, my team in Kaohsiung Chang'e Memorial Hospital with neurologist and neuroradiologist and my stroke team. I thank you for your attention. I will take questions at the end. Thank you very much.
Thank you, Jimmy. You mentioned that I think this is this kind of estimation for this kind of collateral or perfusion condition is quite useful for making the surgical plan and how to treat the disease. But you know, the typical 𝑚𝒉𝑚 disease will progress, and in my opinion, we can't only consider the current situation, but also in the surgical treatment, we should provide sufficient margin for future disease progression. So I always try to give the cortex, the ischemic cortex, as much as new ECA perfusion from the different layers of the arteries. Actually, the ECA arteries, including three arteries, the scalp is STA, temporal muscle middle is deep temporal artery, and the middle meningeal artery for the dura. So all we can use is this three layers arteries, and I always perform the combination use of these three arteries for to give the ischemic condition cortex as much as the new perfusion from the ECA arteries.
That's very true.
Mm-hmm.
I have some patient that initial survey, his rapid study, the Tmax is not more than 6 seconds. Right now, I cut the line, the threshold at Tmax 6 seconds. So if the patient, his Tmax is not more than 6 seconds, I will not do the surgery. And I have 3 patients, they're teenagers. Their initial, their Tmax is not more than 6 seconds. So I do not do the surgery, just a little bit TIAs. But as the time goes, I keep monitoring and follow up in 2 or 3 years. They start get more and more TIAs, and I follow up with the rapid. At the same time, their Tmax, their perfusion get worse, and they start to have Tmax more than 6 seconds. So I start surgery. So in my personal experience, I think the rapid for the Tmax 6 seconds maybe can become a new threshold for the surgical indication.
Yeah, but you know, we also have a lot of pediatric patients, and we did some follow-up work. But most of the patients finally they got progress and needed surgery. And I also noticed that in some special cases that treated by other countries like Korean neurosurgeons, they use 𝑬𝒙𝒑𝒆𝒂𝒃. Only 𝑬𝒙𝒑𝒆. It's in some years maybe efficient, but after the progress of the disease, it become not enough. So I have to do the additional treatment. So sometimes I only even use the coronary incision and even the from the posterior circulation to do the occipital artery to PCA bypass. Yes. So,
yes.
But if we treated the patient at the first stage, use a very wide 𝑬𝒑𝑚𝑠, that's enough for the patient mostly. Only two procedures. But then sometimes if you use only a very narrow 𝑬𝒂𝒔, finally we may need 4 procedures.
If the patient is the kid, a pediatric patient, I'm totally agree with you. But if the patient is an adult, I feel that 𝑬𝒂𝒔 is not enough. And but I do the NOVA for all of my patients. I have some observation that is very valuable. So after the surgery in 1 year, you can see the middle meningeal artery and superior temporal artery that also show the increase in the flow at the same time after the bypass surgery with direct and indirect. 2 years later, you will find that the superior temporal artery, the flow start to decrease. But the middle meningeal artery, what we know is an extra carotid supply, still go upward. So my hypothesis is the brain feel his perfusion is enough. Then his stimulation to the superior temporal artery may be decreased, that make the superior temporal artery bypass become decrease in the flow. That's a point that I feel that the indirect is still necessary for the surgery. So right now I do both at the same time. I usually say that it's like the tree implant. We plant the tree, then when the tree grow up, then he get more water, and the tree grow up more. And this is like the bypass surgery for indirect.
Yes, that's why I insist combined approach. Both use direct and indirect. Yes. And you mentioned that you use 3 stages for the but you know, in typical moya-moya disease, the stage 2 may be normal, but in some other moya-moya syndromes, actually the patient can skip the stage 2, directed to the stage 3, from stage 1 to stage 3, to
yes.
In fact directly. Yeah.
Yes, I agree.
Okay, thank you, Professor Zhang, and a very nice and a very informative presentation. And I think this topic is very important for us to do the surgical strategy and how much blood flow we should give the patient's cortex. It's very important. Thank you.
Thank you very much. Thank you, Professor Shibin.
And Chairman Appeal, Professor Appeal, do you have some comments? And
no, I don't have many, because in fact in Brazil we don't have many moya-moya diseases. We see very few patients, and most of them in children. So adults are very, very rare. But in children we see a few of them, but our pediatric neurosurgeon deals with that. So, but in our experience, local experience, we do the indirect treatment for children instead of direct. That's what we do. But this is a small experience, so you can hear about much more from you.
Okay, Professor Park. Professor Park, I think Korean neurosurgeons also treat a lot of moya-moya disease. Do you have any comments? Yeah.
I would like to ask some question about the speaker. Is there any, do you have any selection criteria based on the cerebral blood flow study for the selection of surgical patient candidate?
Oh, you mean?
Do you have any, actually you explained the various kind of the cerebral blood flow study.
Yes.
Right?
Yes.
And then on the basis of that study, then is there any selection criteria on the basis of the cerebral blood flow study?
Okay, good. I have mentioned once that if the patient come to me with the diagnosis already with bilateral 𝑬𝒚 disease, if his rapid CT perfusion with rapid analysis no more than Tmax 6 seconds, I will not operate. I will just observe. If the patient with more than Tmax 6 seconds with TIA, I will operate. And for the adult bilateral 𝑬𝒚 disease, I have 30% of patients do not need to do another side because only one side get benefit to another side. But for the children, no, you have to do both sides. This is my experience, but just only based on 60 to 70 patients, not very much.
Okay, then I have another question. Then, is there any specific reason to the direct surgery for very pediatric patients, very young age patients? Actually, you did.
You say direct?
Yeah. Yeah.
Okay. Initially, I know there's many pediatric neurosurgeons only do indirect, and the evidence shows it's effective. So I believe that only indirect is enough for the small kids. That means that indirect, the potential is very good in pediatric, but not very good in adult. But my teacher teach me initially do both. So I do both from the beginning to now. But in pediatric, I believe only do the indirect is enough because the collateral potential is very strong.
Okay, thank you.
Thank you, Professor.
Okay, Ben, now shall we move on to the third speaker? Yeah.
Yes, thank you, Professor. If there's no more question, then should I invite Professor 𝒁𝒑 to introduce our third speakers and his topic of presentation?
Okay, now let's invite the third speaker, Professor Park from Korea, and his presentation topic is a very standardized technique of direct revascularization for 𝑚𝒚 disease. Let's welcome.
Okay. First of all, though, I'd like to say thanks to the Yokogato and then organizing members for inviting me and giving me an opportunity to share my experience with the audience. Then today, my topic is the very standardized technique for the indirect revascularization surgery for the 𝑚𝒚 disease. Actually, as you know, the 𝑚𝒚 disease is the mysterious one. Then it is related with genetic factor from origin. But what kind of factor affect the clinical manifestation and the radiological manifestation? But we don't know. So that's why there is some factor affecting. There might be some factor affecting the clinical manifestation, but they still remain in the black box. Then we can classify the clinical presentation of the 𝑚𝒚 disease as like this: non-symptomatic and the symptomatic. And in symptomatic, we can have the ischemic type and hemorrhage type. And in ischemic type, we can divide into the TIA and the permanent cerebral infarction. In non-symptomatic, some patient has no progress. Some patient has progressive. I think that this one is very hard to identify this one. Then this year, the Chinese group did the meta-analysis about the potential predictor for the progression of the 𝑚𝒉𝒄 disease. And they found the age factor, breast age, and then family history, and the contralateral abnormality there could be a contributed to the develop the progression. And if we observe the 𝑚𝒉𝒄 disease carefully, then we could find the constant clinical finding like this one. The first one is the most cerebral infarction has occurred in the border zone area, which means the internal border zone and the external border zone. And most hemorrhage has occurred around the ventricle, which means the junction between the ventricular-pedal and the ventricular-femoral artery. And most hemorrhage event has occurred in advanced stage of the 𝒁𝒑 disease. And then if we did the successful revascularization, then we can see the regulation of the dysplastic artery in angiography. And this is the example of the cerebral infarction located in the internal border zone and external border zone, which means the hemodynamic instability contributed to the cerebral developing cerebral infarction initially. And this is this CT scan shows the location of the hemorrhage. Most hemorrhage is located around the ventricle. Then that's why the hemorrhage has occurred around the ventricle. And this is, means the most hemorrhage has occurred in the advanced stages. And why the hemorrhage occurred around the ventricle? Then in angiography, we can see the very dysplastic vessel around here. In preoperative angiography, this area may be the maximal hemodynamic stress area. Then possible mechanism, we can explain the possible mechanism of the hemorrhage in 𝒁𝒑 disease, like this figure. Actually, this area is the meeting point from the ventripetal direction artery from everywhere. But the 𝒁𝒑 disease involved the middle cerebral artery and the internal cerebral artery as something. Then digital area of the middle cerebral artery was something. Then there might be the hyperperfusion. Then the long perforator became to be disappeared. Then many perforator from the middle cerebral artery, actually this is the ventricular artery, they try to irrigate this area as well. Then they need connected dysplastic vessel. This plastic vessel, then through the dysplastic vessel, they can connect the long perforator, and the direction of the vessel has been changed from the ventricular-pedal to the ventricular-femoral. That's why the hemorrhage, this area is the maximal the hemodynamic stress area and very weak point. That's why the hemorrhage always occurred around here. And another clinical finding is if we do the extensive extensive revascularization and the revascularization has been successful, then we can see this plastic vessel, disappeared after operation. This is post-operative one. This plastic vessel, we could not see that kind of vessel in the post-operative angiography. Then we can explain this phenomenon like this one. If in direct revascularization has been established, then they can irrigate this area with direction of the ventricular pedal direction. Then this plastic vessel has been will be disappeared after the successful irrigation from the cortex. Then, which means this finding means actually the revascularization surgery seems to be the only meaningful treatment for the 𝑦𝑚𝑚 disease, and then surgical candidate could be this yellow area, the progressive one and symptomatic. Then which kind of we can select the indirect, direct, and combination revascularization, but there's a lot of the pros and cons about this area. Then last year, there was a systematic review and the meta-analysis, and then in their publication, actually the rate in terms of the late ischemic stroke development, the direct surgery and combined surgery is superior to the indirect one. This one. And in terms of the rate intracerebral hemorrhage, they're the same. The indirect is inferior to the direct and the combined surgery. And finally, combined surgery is superior to the indirect for getting the favorable outcome. But this angiography shows the combined angiography shows the STA, the irrigation territory after 14 days after combined surgery. Actually, the STA irrigated the very limited small area. Then, unlike this one, then if we do the bypass surgery for the atherosclerotic occlusion patients, then we can see the large irrigation area like this. Then the right side, the angiography is taken after 1 year after the combined surgery. The same patient, we can see the many irrigation area is done by the indirect surgery rather than the direct surgery. Then actually this is the case of the indirect revascularization. Revascularization is the area is very large, and there was a very successful irrigation from the indirect vascular flap. Then there might be pros and cons. The indirect surgery is relatively easy, but the main disadvantage is the very vulnerable to the post-operative ischemia, and sometimes we can see the failure of the revascularization. For direct surgery, it provides good and immediate revascularization, but the direct, sometimes we experience the very fatal post-operative hemorrhage after the direct surgery and the hyperperfusion syndrome, and it is not easy one, technically demanding. The combined surgery most advantage is it can provide more robust vascularization area than direct surgery, but they have the disadvantage of indirect and direct both. Then we will, I would like to discuss with, from the perspective of the very beginner, I'd like to discuss about the post-operative, the complication, the disadvantage of the various surgical technique. Then first one, then for direct surgery, actually the post-operative hemorrhage is main disadvantage, and sometimes it could be fatal. Then there are several sporadic reports about the post-operative intracranial hemorrhage after ST-MC anastomosis in 𝑦𝑚𝒉𝒆 patient. Then always the author says they are extremely rare, but the fatal complication, but there is no effective prevention, and which means that it is very hard to control or modify. Then actually we know because of the chronic hyperfunction in the brain in 𝑦𝑚𝒉𝒆 patient, there is a increase of the MMP9, the enzyme, kind of enzyme, matrix enzyme, then which contributed to the development of the postoperative intracerebral hemorrhage. And which means we can there might be a mechanism of the postoperative hemorrhage after direct surgery, will hyperfunction syndrome, and the other one is the increased expression of the serum MMP9, which means it is very difficult to modify for this one. Then we are going to the indirect surgery. Then for indirect surgery, most main disadvantage is the development of the postoperative ischemia. Then actually this ischemia is caused by the improper management of the perioperative hemodynamics, and then which means the improper hydration and the management of blood pressure, and the environment, the failure to correct environment, the decreased for the auto carrying capacity. And sometimes we use the donor flap for revascularization, but the donor flap could compress the brain, then they cause the local function disability. But this item, it is more easier to modify It is more easier to modify. Then another main disadvantage of the indirect is sometimes the revascularization, the revascularization failure. And actually, I will show in order to explain easily, I will show some experiments that I did many years ago. Then actually in this experiment, we should know about some basic the protein expression. Actually, in the hypoxia, then due to the development of HIF, then we can see the elevation of the angiopoietin 2 and the VEGF. Then this protein can normally this protein contributed to making the unstable vessel. And the other one is the angiopoietin-1. Angiopoietin-1 is related to the making the matured stabilized vessel. And actually, we made the internal carotid occlusion model, bilateral internal carotid occlusion model, like this. Then after 7 days after, we do the EMS like this. Then after 14 days, we take the sample and then evaluate for expression of the various protein. Like this. And we can see the development of the newly formed vessel into brain. Then this is the sham operation, then occlusion model, then after EMS. Then we can see the increased the vessel density in the around here. Then most of the density is high, but after EMS, this side density has been decreased. Then enlarged vessel number, they increased in the EMS group. And this is the expression of the various kind of the angiogenic factor. Then actually the occlusion model, we can see the elevation of the VEGF and angiopoietin-2. But after EMS, we can see the decrease of the VEGF and angiopoietin-2, but we can see the increase of the angiopoietin-1. Then this means the after in chronic ischemia, then bilateral occlusion model, there was expression of the VEGF and angiopoietin-1, which contributed to the immature, making the immature vessel. But after establishment of the anastomosis, then this kind of the angiogenic factor has been decreased, and the angiopoietin-1 has been increased, because to make the good vessel. Then there was another interesting report was published in 2019. Actually, the Japanese group do the similar operation in the 𝑣𝑚𝒆 in the brain, the 𝑣𝑚𝒆 brain. They did the EMS as well. Then they found some very interesting finding. Then after revascularization with EMS, there might be fibrous coat formation, which contributed to the angiogenesis. But in donor side, in recipient side, if there was no ischemia, this angiogenesis formation fibrous coat going to be the cicatrization just. Then if there is ischemia in recipient side, then this angiogenesis, the fibrous coat is going to develop for arteriogenesis, which means they can can have the revascularization successfully. Then, which means we can summarize like this: if the indirect bypass do the did, then there might be a fibrous coat formation, which means which is the tissue providing vascular bed for angiogenesis. Then after this formation, then if there is a ischemia or the cerebral hyperproption in the recipient side, there might be elevation of the angiogenic factor, and there might be a pressure gradient between donor flap and recipient bed, and there might be a fluid shear stress. They contributed to the making the new vessel, new sound vessel, the arteriogenesis, which means the functional revascularization. But there is no ischemia and no malperfusion. There might be no angiogenetic factor and no pressure gradient and no fluid shear stress. Then they could not make the new revascularization. Then, which means that is not real failure. That is just a phenomenon because there is no need of the revascularization in the brain. The fish technology, I think that in terms of from the perspective of beginners, fish technology is more commoditized and easier to disseminate. I think the indirect revascularization is more compatible to the pathophysiology, and the indirect revascularization is more safer and relatively easier and technically easier. And if they use the correct method, I think that it could be an alternative. The indirect revascularization is the same effective if we make the correct patient selection, and it could be good effective. Then finally, I would like to show the standardized technique for the indirect revascularization. And actually, we pre-operative and intraoperative management, then we should keep the proper hemodynamic status for patients, and which means that we have to do proper hydration before surgery, and if there is some ischemic event, then we will have to delay the surgery for patients, and the careful anesthesia should be mandatory. And if we can do the intraoperative electrophysiology monitoring, it will be better. Then this is the ear and the frontal and occipital, the parietal. Then this is the line of the STA, parietal branch. This is the frontal branch. Then actually we can make the skin incision like this, the T shape, like this one. Then after skin incision, we can see the STA, parietal branch like this. And if we peel off from the gallia, we feel the scalp from the gallia like this, and we can see the STA and the STA frontal branch. And actually, we can make the gallial flap like this. Then STA front parietal, STA frontal here. Then we can make the vascular flap like this. Then this is the vascular flap. Then after making the vascular flap, we can incise the temporal muscle like this. Then peel off the from the bone, and then we have another incision from here for passing the frontal branch of the STA. Then after the peeling off the temporalis muscle like this, then we can make the bore. This is for passing the proximal part of the STA. This bore for the passing the parietal branch, and this bore for the passing the frontal branch of the STA. Then we can make the bone flap like this. Then after making bone flap, we can see the middle-meningeal artery. Then if we want to use this vessel for donor vessel, then we can make the dural flap like this. And at this moment, we can see the deep temporal artery as well, which could be contributed to the donor vessel. But in this case, we don't need this one because the middle major artery is okay. But sometimes if the middle major artery status is not good, then we can use this vessel, this flap from here. Then after flipping of the dura like this, then we suture the water tightly like this, cover the whole large area of the hemisphere like this one. Then after suturing, making the dural area, then we have to we put the bone flap like this. Then we have to keep the patent STA like this. Then we can make some small holes for draining of the epidural space fluid. Then after fixation of the bone flap, we close the temporalis muscle like this. And we close the skin like this. Then post-operative management, then we have to keep the proper hemodynamic state. We have to think about always about the oxygen dissociation curve for maintaining the proper oxygen delivery, especially for the hemoglobin level, and then hematocrit is very important one, I think. If there is a ischemic event during post-operative state, do not hesitate to start the hypodynamic treatment immediately. And that is my strategy for the indirect surgery. And then thank you for your attention. And I would like to say this one for take-home message for perspective of the beginner for treatment of the neurosurgery at the 𝑨𝑚𝑉𝒆 disease. Okay, thank you very much.
Okay, thank you, Professor Park. Jimmy, do you have any comment?
Yeah.
Oh, yes. So, Professor Park, it is very beautiful surgery. I'm very impressed. I have some opinion about the hyperperfusion syndrome after the bypass, low flow bypass surgery, because I check the flow regularly every surgery, and I usually check the donor and the recipient for the 3-part flow. And I have some feeling, because in the beginning of my career, I following the principle, make the flow maximum as my best. And I found if the flow more than 8 centimeters per minute, the hyperperfusion syndrome will be much more possible. And because I do MR study regularly after the surgery on the discharge day, usually the post-op day 4, I do NOVA and MR regularly. So I can find many cases that do not have syndrome, but MR shows hyperperfusion. So I feel you need to keep your bypass flow around 5. It's perfect. If the bypass flow is more than 8, you have to be careful the hyperperfusion syndrome. This is my very personal opinion, not scientific. It's just personal opinion.
Okay. Okay, thank you for your comment. Then actually in Korea, in Korea, the many neurosurgeons doing the combined surgery as well, especially in adult patients. They do not just do not use the indirect only. But for me, actually there is the sporadic report about the intracerebral hemorrhage after the direct surgery in 𝑦𝑚𝒉𝒆 patient. But I saw that there are many cases actually after indirect. There is a lot of the hemorrhage complication. But there is in publication there is a very small sporadic report. Then personally, actually in Korean neurosurgeon, actually they think the standard treatment of 𝑚𝒉𝒄 disease should be the combined surgery. Actually, many neurosurgeons are doing that kind of things. But for me, I think that if there is a post-operative hemorrhage, then it is not irreversible, right? It is not irreversible. But in case of the ischemia, then especially in the young age, then it can be reversible, right?
Okay.
Yeah.
Okay.
That is my philosophy, just the philosophy.
Okay.
But actually but my friends do not agree with me. Right? In Korea, the many Korean surgeons doing the combined surgery, right?
That's good. Thank you very much. Thank you.
Okay, thank you.
Okay, talking to the hyperperfusion syndrome after the bypass, Dr. Zhuang, do you notice that some actually, if you do the MRI perfusion examination and at the same time, if you use suspect examination, actually you can find some different in the different patterns. And in my experience, actually after the bypass, around 40%, actually it is the patient, it has some hypoperfusion syndrome, but not the hyperperfusion syndrome. Only around 60% is a real hyperperfusion. But actually, maybe because of the congestion of the veins, actually the perfusion in some patient after the bypass is decreased, not increased. So also, so that's why the patient also presented some ischemic symptoms, but not the hypoperfusion syndrome, like seizures and some overactive of the cortex. Do we have some same experience?
How do you know they are decrease of perfusion? So you check the study after surgery?
Yes, yes.
Oh, okay.
Yes, you suspect.
You suspect, okay.
Mm-hmm.
Actually, no, but I have one case that cause-of is hyperperfusion infarct bilaterally. But during the surgery, the flow is very strong. It's almost 10 cc per minute. The flow is so strong. But just immediately after the surgery, he suffered from bilateral MCA infarct.
Yes.
And I'm not sure why. And even that, the bypass is still pattern. It's not occlusion. No, the bypass is pattern. Under the successful pattern bypass, he suffered by bilateral infarct.
Yes.
This is
Actually, in most of the infected patients, normally when you do the creotomy, decompression of the creotomy, you can find the bypass is still patent.
Yes.
Yes.
I only one case, but I don't know why.
Yes.
But there's the literature have some similar case show what you are mentioned for. So you think it's the sealing effect that make the neighboring cortex hypoperfusion? Do you believe is that? I'm not sure the exact mechanism to make this result.
Yes, and that's why we are measuring the pressure in the artery before and after the bypass. We just published our methods in ACTA, but we will publish the further results of the bypass measurement intraoperatively. And actually, we noticed that sometimes the drain vein in the cortex, actually, the drain veins pressure may be higher than the navel cortex of arteries. That's very dangerous because if the veins pressure is higher than the navel cortex arteries pressure, it may cause the infarction of the navel cortex.
So it also result by too much flow from bypass, right?
Yes, yes.
So
yes.
Too much flow from bypass may cause hyper or hypoperfusion. Is
yes,
that your
both? Yes.
Thank you. I got your point.
Both. Yes.
I will think about it. It's very precious.
And thank you so much. Is there any comment from two discussant, Professor Oliseng?
I want to ask Dr. Shubin, during the surgery that you noticed the suspect of the hyperperfusion during the surgery. So do you have any idea how to treat the post-operatively?
Professor Kato, and I think this is a very important opinion because, you know, what's the purpose we measure the pressure change in the artery and the veins? It's the real purpose is to prevent the late ischemic or hemorrhage complications for after the bypass. So if we just like Jimmy mentioned, if the blood flow was too high, and just like Professor Park also mentioned that if the bypass pressure is too high and the blood flow was very high, it's very dangerous for the post-operative hemorrhage. Sometimes even intraoperatively cause the bleeding of the cortex. So we may control the bypass in this kind of case. Sometimes I use some absorbable suture to control the feeding arteries blood flow. And after that, we can cause the control of the bypass. But after the bypass, actually in maybe 7 days, the blood flow of the bypass still can increase from maybe 20 to 30 millimeter per minute increased to even 70 in some double bypass cases, maybe even then 100 millimeter per minute. So sometimes if the patient can tolerate very well, it's okay. But sometimes if it's a later stage of the Suzuki of the 𝑣𝑚𝒺 disease, maybe it's very dangerous. So that's actually, in my opinion, every case of 𝑚𝒺 is different, and we should analyze the case by case, and only we can understand every aspect of the hemodynamic change, then we can give the patient a new and safe treatment, including Professor Park mentioned some indirect treatment. So we couldn't use a universal treatment to treat all the myeloma disease.
Thanks so much.
I'm doing the same thing like Professor Sh-bin. So right now I'm very look critical to the hyperflow. So after the bypass, if the flow is too high, especially more than 8 cc per minute, I use rapid 6-0, try to make the proximal STA more narrowing to try to decrease the flow. I do 2 cases, just like Professor Sh-bin mentioned.
Yes. Sometimes if the patient after several days, it have some hyperperfusion syndrome. I also use some glove and use one finger of the glove and put the plastic glove into the one finger and then press here to press the STA to control the blood flow. That's that's a small trick. Yeah.
Thank you.
Is there any comment from our discussion, Professor Priest? Do you have any comments?
Thank you, Professor Park, for excellent presentation. Thank you very much, and it's like a controversial issue, and it needs more discussion. Thank you very much. It was great. Thank you.
Thank you.
Thank you. So there's a question in the chat box from Dr. Raffle. Is there any scope for the gene therapy that can help with the neoangiogenesis with the surgical intervention? Maybe this to the Professor Park and also Jimmy. And do you aware of any gene therapy?
I hope I know.
I have no experience. I have no idea about it.
Yeah, but I think it's very dangerous. It's even more dangerous than surgery.
Yeah. Yes.
Yeah.
Probably.
I think that the 𝑨𝑚𝒂𝑚 disease, actually the kind of the genetic basis disease, but I think the more important one is the epigenetic factor. If there is the patient have gene, but the environment will change their expression, as I said in my first slides. And that's why then I think that it is very hard to get a gene therapy for 𝑨𝑚𝒂𝑚 disease.
I see. Okay, is there any questions from the floor? If not, shall I invite Professor Kato to give some comment?
Maybe Dr. Monsignor, any comment?
Yes, thank you, Professor Kato. So in my country, we do not see so many cases of 𝑨𝑚𝒂𝑚, so that is why I have not a big experience with this pathology. But anyway, I have a questions to maybe to all of the presenters and the discussant. We speak about mechanical revascularization. We speak about restoring of hemodynamical blood flow, but in sense of microvascular, microcirculation, how much is it important? Is it important to keep the level, the glucose level, cholesterol level, blood pressure level for the patient who were operated on for revascularization? How much it is important pre-operatively and post-operatively? Maybe let us discuss this question. I think it's very important for this cohort of patients. Maybe this is a question to Professor Park, because he mentioned about hyperhydration and blood pressure. So I'd like to extend a little bit, put a little bit more to cholesterol and glucose level.
Yeah, I think that it might be related with the blood viscosity, especially in the cholesterol or something. But the more important one is the inflammation index, the inflammation index. Then actually the other thing is the more I think that the blood glucose level should keep below the maybe the 200, right? And actually we have the very we control the blood sugar very strictly before operation. But many patients has young, then they don't have the glucose disturbance. And actually the cholesterol is the same. Actually, the young patients, they don't have the cholesterol disturbance, but in some cases, in other cases, then actually we better to control the cholesterol level. I think in post-operating period, I think the most important thing is the hemoglobin level. Sometimes actually the 𝑚𝒉𝒄 patient, maybe they go to mountain. There is some 600-meter high, then they can experience ischemia. Normal patient, the normal person do not experience at that level the ischemia at that level, but which means that it's very sensitive to the oat carrying problem. That's why I should keep above the hemoglobin level 10. I should keep. Then I think the hydration is for hydration. I think it is more important in pre-operative period. Before surgery, 1 or 2 days before surgery, then we normally start to the hydration. So for adult, about 2 liter per day, right? Yeah, about it depends on the patient's the body size. Yeah, I think so. I think the hemoglobin is the most important one. I think so. And after in my best the beginning period, then I do not recognize that kind of things. I did not recognize. Then there is some the painful experience for me. And actually at that time I reviewed the chart and there was just some fluctuation in the hemoglobin. Then after that I tried to keep the very strict the hemoglobin level especially in the post-operative period. Thank you.
Okay, thank you. Great comment. Thank you very much. That's very interesting. Thank you. So,
Matsushima says, any comment? Because the Kyushu University has lots of 𝑚𝒉𝒄 research and the clinical cases.
Yeah, yeah. 30 years ago, I reported my surgical result, the comparison between the direct and indirect bypass surgery in neurosurgery. I experienced 40 years 𝑚𝒉𝒄 disease. From my 40 years experience, revascularization method is not big problem. Now, the biggest debate in Japan is a conversion of the type. When patient develop the ischemic type in the children, but 20 or 30 years later, even though patient receives the revascularization, they develop the hemorrhage. Do you know? Hemorrhage in the 𝑚𝒉𝒄 patient is a ventricular hemorrhage, intraventricular hemorrhage. So intraventricular cause of the interventricular hemorrhage is a proliferation of the periventricular anastomosis, which is related to the choroidal artery. So you need to be very careful. Suzuki's stage 4 and 5. You need to watch the finding of the vertebral artery. That's my suggestion, comment.
Yes, I
Thank you
totally
so much
agree
for
with
your-
you, Professor Mitsushima. And I just mentioned that this disease will progress. Sometimes actually the hemorrhage of the moya, the main cause is the ischemic condition. It's the ischemic condition caused the hemorrhage finally. So that's why I insist.
Periventricular hemorrhage. That is caused by the proliferation of the periventricular anastomosis.
Yes, but it's ischemic condition cause the proliferation of the moya vessels, just as Professor Park mentioned in his presentation. Yes. So the main cause of the hemorrhage actually it's ischemic condition. Finally, it's caused.
Let me speak. I have experience of the ruptured aneurysm of the moya disease. I operated on the 3 cases. All cases has a periventricular aneurysm fed by the posterior choroidal artery. So you need to watch the MRI, periventricular area. When you find the small aneurysm, you need to consider the more surgical treatment. Now, Dr. Funaki at Kyoto University recommends the targeting bypass surgery. Now we are searching for which part should be revascularization to prevent the intraventricular hemorrhage. I don't know exactly, but now we are considering to protect the intraventricular hemorrhage.
Yes, but I think it's different because the peripheral aneurysms of the moya, we actually can use sometimes use interventional treatment to obligate the feeding artery of the aneurysm directly, and sometimes if the aneurysm located in the main branch of the sulcus villus, we also can treat the interventional treatment, use coils and stenting, and if it's a peripheral, totally pseudoaneurysm located in the cortex, this kind of this kind of peripheral pseudoaneurysm, we can just wait. After the revascularization, normally it can be disappeared. So it's also different.
In the case of the vaginal tip aneurysm, you can use the interventional treatment, but periventricular aneurysm, you cannot use the interventional treatment. Yeah, thank you.
Yeah, ありがとうございました、松本先生。
And for the hemorrhage moya, I have some observation. Right now, there's only one trial from Japan that indicate that hemorrhage moya can be operated with bypass surgery. My opinion is I find most of the hemorrhage moya, when you do the surgery, their moya vessel will be regression. after the bypass surgery. You can see under the angiogram. I'm not sure the regression of the 𝑬𝒙𝒂 vessel is just correlated to the decrease of the hemorrhage rate. So in my team, if the patient had suffered from the first time hemorrhage under the 𝑬𝒙𝒂 disease with normal perfusion, usually I do not operate. But if he hemorrhaged twice, recurrence, I will operate and follow it with the angiogram. Usually I do not follow with angiogram, but hemorrhage 𝑬𝒙𝒂, I will follow with angiogram. And I can see the 𝑬𝒙𝒂 vessel regression after the bypass.
Yeah, when I started my treatment of 𝑚OYA disease, I consider the risk of the direct surgery. Then I did not recommend the direct surgery to the 𝑚OYA patient with hemorrhage. But after the Dr. Miyamoto's study, direct surgery reduced the hemorrhage. So now I'm following his opinion. I now recommend the patient with hemorrhagic type to receive the direct surgery. But to focus on is decrease the periventricular anastomosis, not basal 𝑚OYA. 𝑚OYA vessel includes 3 or 4 types. Periventricular proliferation of the posterior choroidal artery is a new 𝑚OYA vessel. So we need to decrease the 𝑚OYA vessel around the lateral ventricle. That's my opinion now.
Thank you.
Thank you. If there's no further questions, shall I invite Professor Kato to make some final remarks?
Sensei, thank you very much for your very recent
Sorry, my English is very difficult for you.
We all understood. I think choroidal artery is one of the topic in the 𝑚OYA disease now. And also, I think preoperative image is another very important thing, because you mentioned about the target bypass already. Dr. 𝒀𝒵 is he used every time, but Dr. Park, he mentioned, he emphasized about indirect surgery, the importance of the indirect surgery. When we want to do additionally the indirect surgery, maybe we need a bit more bigger craniotomy. So the target bypass is very fancy and good, but sometimes we need when we want to do the additional indirect surgery, maybe we can have a more wider the surgical field, I think. I think the recent research of the preoperative very excellent image, such as a superimpose of the such kind of perfusion image plus STA vessels. I think for the next generation, I think we need the more or less invasive treatment for the patient. So we had a very nice the 3 speakers, also good commentators, and also the 𝒀𝒵. Thank you very much for the very valuable your 𝑚OYA comments.
Yeah, thank you, Professor Kato. And today we have around 450 neurosurgeons attend this webinar in WeChat. Thank you.
Thank you very much. Okay. So
Thank you. Thank you.
Thank you very much.
Bye.
Thank you very much.
Bye bye.
Bye bye.
Thank you.
thank you
Again.
so much.
Bye.
Thank you so much. All of you.
Mom says bye bye.
Bye bye. Bye bye.
We'll see you next time. Thank you so much. A really wonderful discussion tonight.
Yeah,
Great.
very
Thank you.
informative. Very good.
Yes.
Thank you very much.
Good night. See you, my friend.
Thank you.
See you next time.